Hello, good afternoon, and welcome to everyone in the room and those joining us live today to the 83rd Presidential Advisory Council on HIV/AIDS, also known as PACHA, Full Council Meeting. My name is Marlene McNeese. My pronouns are she and her, and I am currently the co-chair, sole-serving co-chair presently of PACHA, and I serve as Deputy Assistant Director with the Houston Health Department, overseeing our Bureau of HIV, STI, and viral hepatitis prevention. Before we get started in our meeting, I'd like to briefly define the PACHA Charter, its charge, and its mission. PACHA provides advice, information, and recommendations to the Secretary of Health and Human Services regarding programs, policies, and research to promote effective treatment, prevention, and the cure of HIV and its related syndemics. This includes the Ending the HIV Epidemic in the U.S. initiative and monitoring the implementation of the updated National HIV/AIDS Strategy. Through the Office of the Secretary, PACHA may also make recommendations for consideration by the Director of the White House of National AIDS Policy, also known as ONAP, as appropriate, concerning implementation and progress toward achieving strategy goals. I want to emphasize a few basic reminders for all PACHA members. PACHA must vote on recommendations during a full council meeting. PACHA is solely advisory in nature. PACHA members are also special government employees, and therefore the Hatch Act applies during PACHA duties. PACHA does not advise non-HHS agencies or Congress. PACHA is not a funder nor the voice of one person. And we make recommendations, we do not make mandates. And lastly, PACHA members cannot make partisan political comments or discuss upcoming elections during PACHA duties. Since we last met, we have, unfortunately, lost one of the giants in the response to HIV. Mr. Cornelius Baker meant so much to so many people, and I don't know if we will ever be able to quantify or measure his impact on the lives of people living with HIV and for so many infections that he averted, directly contributing from his advocacy. Many of us have made changes in our schedule for this week to attend Cornelius's memorial services on Friday. So I do want to thank you all for being flexible in your travel and with our agenda to accommodate that participation. And then I'd be remiss to not also mention a bit of a celebratory note. Our very own Dr. Laura Cheever has formally announced her retirement. And so our partner and colleague for many, many years in the work will take her deserved rest. And so really just wanted to acknowledge Dr. Cheever, who's been such an important ally and brilliant partner and thought leader in our response in this country to HIV. Thank you. I'm also excited, obviously, about our agenda here in Montgomery, Alabama over the next few days. I'm hearing from many of the PACHA members around the table about how impactful the engagement visits, the in-person visits were on yesterday. I'm sorry that I missed those, but was thrilled to participate in New York State's AIDS Institute's Ending the HIV Epidemic Summit that began on yesterday. Again, one of our nation's jurisdictional leaders in the HIV response who are recommitting themselves to a path forward for many communities who've yet to realize EHE goals. So today, I will also want to ask that you join me in a round of applause for the incredible leadership of Miss Daphina Ward for helping to shape. She has helped to shape our experiences and conversations for this engagement here in Alabama. So thank you so much, Daphina, who is going to tire of me giving her the spotlight. I can't help myself. And then today's agenda, we have a lot packed into this afternoon. We do have a shortened day for our day one of the meeting. After we do our business of roll call, we will have some introductory remarks from Dr. Admiral Levine. We will hear a bit of a message from our ONAP partner and colleague, Francisco Ruiz, about some important updates that he is working on. And then, of course, we will get into a welcome to Alabama from Dr. Scott Harris, the state health officer here. And after we take a brief break, we're really going to dive deep into a conversation this afternoon that will be expertly guided by two of our very own PACHA leaders, Jesse Mylan and Alicia Diggs. So we'll hear from some important folks here. And then following that, we will talk a little bit about the epidemiology of HIV in Alabama, and that will be facilitated by Drs. Patrick Sullivan and Dr. Hansel Tukes. So with that, we'll have some time for Q&A. So PACHA members, please make sure that you raise your tents to get in queue, that we are expertly using our microphones. Please, if you're not speaking, please turn the microphone off and speak directly into the mic. Just a reminder, we have a number of people watching and listening on Zoom. So in order to hear our conversation, we have to speak into the mics. And then lastly, we will have some department updates, specifically around what's happening on the global front, starting with Dr. Jane Cates. And then we'll hear from Adrian Shanker, former PACHA member, and Brian Kaplan, who will talk about some important department OIDP updates as well, before we wrap up and recess for the afternoon. So with that said, I am always proud and happy. My partner in organizing all of this chaos and information to bring thoughtful discussion to the work that we do. Carolyn Talib, she is the executive director, as we all know, of PACHA, and she's in the Office of Infectious Disease and HIV/AIDS Policy, and she's going to facilitate our roll call for today. Carolyn.
Thank you. So we will start with our PACHA members. We'll just ask for your organization, location, and which subcommittees you serve on. So PACHA Chair Marlene McNeese.
Present. I serve on all of our subcommittees, hailing from Houston, Texas. Thank you.
Guillermo Chacon.
Present, Latino Commission on AIDS throughout the U.S. and Puerto Rico, U.S. Virgin Islands, and I serve as a co-chair to the Ending the Epidemic. Thank you.
Thank you. Philip Chan.
Good afternoon, Philip Chan from Providence, Rhode Island, Brown University and Open Door Health. I serve on the Ending the HIV Epidemic subcommittee.
Tori Cooper.
Present, Tori Cooper, Human Rights Campaign. I serve as co-chair with Guillermo on the Ending the HIV Epidemic Committee.
Rania Copeland.
Good afternoon. My name is Rania Copeland. I'm with Equity and Impact Solutions consulting firm. I serve as co-chair for Stigma and Disparities Subcommittee, and I hail from Los Angeles.
Mackenzie Copley.
Good afternoon. Mackenzie Copley. I lead 110 Health in Washington, D.C., and I'm on the EHE subcommittee. Thank you.
Jennifer Cates.
Good afternoon. Present. I'm from KFF in Washington, D.C., and I'm the co-chair of the Global Subcommittee.
Paul Kawada.
Present. Paul Kawada, NMAC, Washington, D.C., and too many committees to remember.
Duvia Lozano.
President Duvia Lozano, Chicanos por la Causa, Phoenix, Arizona, and I serve on the Ending the HIV Epidemic subcommittee. Thank you.
Tiomi Luckett. Tiomi Luckett. Jesse Mylan.
Jesse Mylan, President and CEO at AIDS United, headquartered in Washington. I serve as co-chair with Alicia Diggs on the HIV and Aging and Long-Term and Lifetime Survivors Committee, and also serve on the Global HIV Committee.
DeAndre Moore. DeAndre Moore. Leo Moore.
Good afternoon, everyone. Leo Moore, Los Angeles County Department of Public Health, Los Angeles, and I am co-chair with Rania of the Stigma and Disparities Committee. Happy to be here.
Laura Platero. Laura Platero. Kayla Quimbley.
Good afternoon, everyone. This is Kayla Quimbley Young speaking. I serve on the Stigma and Disparities Subcommittee and a former ambassador for Advocates for Youth.
Thank you. Natalie Sanchez.
Good afternoon, Natalie Sanchez from University of California, Los Angeles, and I serve on the EHE as well as the Stigma and Disparities Committees.
Patrick Sullivan.
Present, Emory University. I have the privilege of co-chairing the global subcommittee with Dr. Cates, and I serve on the EHE subcommittee.
Jeff Taylor.
Hello, Jeff Taylor, he, him pronouns, HIV and Aging Research Project, Palm Springs, and I'm the incoming co-chair for the HIV, Aging with HIV Long-Term and Lifetime Survivor Subcommittee.
Marvell Terry II.
Good afternoon, Marvell Terry II, Atlanta, Georgia, Founders Concerned About AIDS, and I am a member of the Stigma and Disparities Subcommittee.
Hansel Tukes.
Hi, Hansel Tooks, University of Miami, Miller School of Medicine, and I serve on the EHE subcommittee.
Carol Treston.
Good afternoon, Carol Treston, Association of Nurses in AIDS Care. We're a global organization with an office in Washington, D.C. I serve on the global subcommittee and I serve on the EHE subcommittee and in particular the workforce work group.
Defina Ward.
Good afternoon, Daphina Ward, Southern AIDS Coalition, South Carolina by way of Alabama. It's good to be home. We serve the Southern United States, regionally focused with making a national impact, and I serve on the Stigma Disparities as well as EHE subcommittees.
Daryl Wheeler. Daryl Wheeler. CDC HRSA Advisory Committee on HIV, Viral Hepatitis, and STD Treatment, Prevention and Treatment, or CHAC Liaison, Wendy Armstrong.
I from Emory University, and I serve as liaison on the EHE workforce, in particular the workforce subgroup.
Thank you. Before I turn it over to our federal partners for the roll call, I did want to acknowledge Kathy Ayers, a former PACHA member who's in the room with us. So I just did want to acknowledge her. So next slide, please, and we'll turn it over to our federal colleagues, and we'll just ask that you say which division you're in and where you're located, starting with Kay Hayes.
Great, present to be here, a Deputy Assistant Secretary for Health Infectious Disease at HHS.
Thanks. Timothy Harrison.
Good afternoon, Tim Harrison, Principal Deputy Director of Office of Infectious Disease and HIV/AIDS Policy, Washington, D.C.
Francisco Ruiz.
Good morning, afternoon, evening. Director of Office of National AIDS Policy, the White House, Washington, D.C.
Brian Kaplan.
Hi, everyone. Great to be here. Brian Kaplan, Immediate Office of the Secretary in Washington, D.C. at HHS.
Adrian Shanker.
Hi, good afternoon. Adrian Shanker, Deputy Assistant Secretary for Health Policy, Washington, D.C.
David Johnson.
Hello, everyone. David Johnson, Deputy Assistant Secretary for Health, Office of Regional Health Operations, Washington, D.C.
John O'Merman. John O'Merman. Robin Neblett Fanfare.
This is Nora Spencer Lovell on behalf of Robin. He'll be down in a moment. Present from CDC in Atlanta. I serve as the Associate Director for Policy, Partnerships, Planning, and Communication in the Division of HIV Prevention.
Thank you, Nora. Andrea Jackson.
Hi, good afternoon. Andrea Jackson, Senior Advisor in the HIV/AIDS Bureau. We administer the Ryan White HIV/AIDS program located in Rockville, Maryland.
Erna Hughes. Rick Haverkate. Kristen Roja.
Present. I am a public health advisor for SAMHSA and serve as an infectious disease policy advisor.
Jerry Donnenberg.
Good afternoon. I'm Jerry Donnenberg. I'm the Director of the Office of AIDS Research at the National Institutes of Health in Washington, D.C.
Jessica Lee. Michelle Schreiber. Michelle Schreiber. Amy Shivakis. Amy Shivakis. Tracy Carson. Tracy Carson. Andrea Callow. Andrea Callow. Casey Knopp. Casey Knopp. Maureen Goodnow.
Yeah, Maureen Goodnow. I'm a senior advisor at OIDP and detail from NIH.
Thank you. Sharonda Brown.
Good afternoon, Sharonda Brown, Office of Infectious Disease and HIV/AIDS Policy, Deputy Director of Operations, Washington, D.C.
Shannon Dowler.
Hi, Shannon Dowler, family physician with OIDP, and I'm located in the mountains of North Carolina in a little town called Marshall.
Shari Jones.
Hi, good afternoon. Shari Jones, Region 6 Director for Engagement, located in Washington, D.C.
And Lauren Wagner.
Good afternoon, Lauren Wagner, Office of Infectious Disease and HIV/AIDS Policy, Engagement Teams Regional Director for Regions 3, 4, and 5. Thank you.
Thank you. And that concludes our roll call.
Thank you, Caroline. Next on our agenda, we are joined by Admiral Rachel Levine, who serves as our 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services and the head of the U.S. Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She's working to ensure health equity is front and center to build a stronger foundation for a healthier future, one in which all people and places in our nation can thrive. Dr. Levine's storied career, first as a pediatrician and adolescent medicine specialist in academic medicine, focused on the intersection between mental health and physical health, treating children, adolescents, and young adults. Then as Pennsylvania's Physician General and later as Pennsylvania's Secretary of Health. She addressed COVID-19, the opioid crisis, behavioral health, and other public health challenges. Let us welcome Dr. Admiral Rachel Levine.
Well, thank you very much, PACHA Chair Marlene McNeese, for your kind introduction. And I certainly applaud you for all of your hard work, your dedication, and leadership for PACHA. So greetings, council members, federal colleagues, community partners in Alabama and across the nation. It is an honor to welcome you to PACHA's 83rd full council meeting. It is wonderful to see our PACHA members and federal partners gathering in Montgomery, Alabama. I see that you will have a thoughtful and inspiring agenda for the next 2 days and be learning about the history of the civil rights movement in the South and its impact on HIV disparities today. And I am so thankful to the local community leaders who will be sharing the story of HIV in Alabama and propose local solutions to advance health outcomes, including HIV disparities. Last week, on December 1st, we celebrated the 37th World AIDS Day with the theme, Collective Action to Sustain and Accelerate HIV Progress. And I think this theme is well illustrated by many of the people that we'll be hearing from throughout this meeting. So thank you to all of you for your steadfast commitment to providing essential services to people with HIV and those experiencing risk for HIV. On World AIDS Day, we paused to remember the 42 million individuals worldwide who have died from HIV/AIDS. We also reaffirmed our commitment to end the HIV epidemic here in the United States and around the world. Just ahead of World AIDS Day, HHS finalized an important rule to improve the quality of life for people living with HIV by streamlining organ donation for kidneys and livers between HIV plus donors and recipients, the HOPE Act. And I'll share more on this in a minute. In regards to the EHE, Alabama is a key partner in our ending the HIV epidemic work. As one of the 57 jurisdictions prioritized in the Ending the HIV Epidemic in the U.S. initiative, Alabama has received additional resources and technical assistance to support innovation and expand community partnerships that scale up science-based strategies to diagnose, treat, prevent, and respond to HIV across the state. The EHE work in Alabama has engaged health centers, Ryan White HIV/AIDS program recipients, University of Alabama, Birmingham, and the State Health Department, among many others. For his work leading the charge to end the HIV epidemic in Alabama, I want to express my gratitude to Dr. Scott Harris, whom you'll be hearing from shortly. In 2018, Dr. Harris became Alabama's state health officer. That's the same year I began serving formally as Pennsylvania Secretary of Health. Dr. Harris and his team have been essential partners in working with the Office of Infectious Disease and HIV/AIDS policy, the CDC, HRSA, and other HHS partners supporting Alabama and the other 56 states and jurisdictions in implementing the Ending the HIV Epidemic in the U.S. initiative. So I would like to congratulate Dr. Harris, his team, and their community partners for all of the work expanding access to HIV services for communities disproportionately impacted with HIV in Alabama. Thank you for your leadership and your partnerships. I'll also point out that Dr. Scott Harris is the president of ASTO, the Association for State and Territorial Health Officials. I'd like to switch gears for a moment and take a moment to update you on some recent OASH activities and accomplishments that I'm very proud of. As you know, since the summer of 2023, I have chaired the National Syphilis and Congenital Syphilis Syndemic Federal Task Force, established by HHS in response to a growing syphilis epidemic in the United States. We recently published highlights of our cross-agency efforts to flatten the curve of the syphilis surge, and all of the federal partners continue to mobilize federal resources, foster health equity, and engage with the communities that are most affected by this public health crisis. As PACHA convenes this meeting in Montgomery, I would be remiss to not acknowledge the painful history associated with the United States Public Health Service syphilis study that the federal government administered at Tuskegee Institute, less than 50 miles from Montgomery. While the syphilis study led to a reckoning of our scientific research protocols, its legacy on issues of race, research, public health, and medical mistrust still lingers today. Now, more than 50 years since the end of the syphilis study, our drive for health equity in response to the epidemics of syphilis and HIV, the syndemic of syphilis, HIV, hepatitis in Alabama, in the South, and nationwide require our continued vigilance. In regards to the HOPE Act, in uplifting equity, our work to ending the HIV epidemic extends to the overall health and longevity and thriving of people living with HIV. With new scientific advancements and progress in policy, we can further support people living with and aging with HIV. With new scientific advancements and progress in policy, we can further support people. And while people living with HIV can and do continue to receive organs from donors with HIV, transplants from donors with HIV may reduce time on the transplant waiting list and associated both financial costs and personal costs for these recipients. So I'm pleased to announce the recent finalization of a rule to expand access to HIV positive organ transplantation. The HIV Organ Policy Equity Act, or the HOPE Act, passed by Congress in 2013, removed the prohibition on transplantation of organs from donors with HIV. This allowed researchers to study HOPE Act transplantation. After more than 500 HOPE Act transplants to date, dozens of publications have described the safety and efficacy of these transplants. And HHS is pleased to announce the removal of research requirements from kidney and liver HOPE Act transplants, making these life-saving procedures more accessible. Additionally, data has demonstrated a significant reduction in wait times for kidney transplant candidates from 60 months to 10 months. In other words, recipients willing to accept a HOPE Act transplant are 3.3 times more likely to receive a transplant. The urgency is clear. As of last month, more than 104,000 people are on the National Organ Transplant waiting list, with a new person added every 10 minutes. By expanding the available organ pool and increasing the utilization of available organs, this policy will benefit all patients awaiting transplants. I look forward to a future where all people living with HIV and end-stage chronic disease will have access to transplantations. My Deputy Assistant Secretary for Health Policy, Adrian Schenker, and Senior Advisor to the HHS Chief of Staff, Brian Kaplan, will share more about this and other important accomplishments later this afternoon. Now, collaboration is instrumental to all the work we do, and working together through this syndemic approach allows us to optimize access to infectious disease testing, prevention, and treatment services. The engagement teams support HHS and advance the EHE initiative in the field. They work with federal partners, states, counties, and community-based organizations to bridge gaps between local and federal work. They also enhance HIV service delivery in regions most affected by HIV. Members of the Region 4 engagement team are currently working to reduce barriers to HIV and other infectious disease services in Alabama, in collaboration with the Alabama Primary Care Healthcare Association and the HRSA-supported Southeast AIDS Education and Training Center. They are working to educate primary care providers across the state on best practices when assessing patients' sexual history as part of routine care. And this is a significant step in ensuring accurate information while easing patient and provider discomfort. OIDP's recent engagement at the U.S. Conference on HIV/AIDS and with the Black Women's Initiative have been pivotal in focusing our support for Southern Black women impacted by HIV. BWI's first internal federal working group, which was moderated by PACHA members Tori Cooper and Dafina Ward, laid the foundation for a unified one U.S. government approach, emphasizing cross-agency coordination to address the health inequities affecting Black women. Next step will focus on priority areas identified in the session, including provider education, community support, and outreach. My office, through the Office for Infectious Diseases and HIV/AIDS Policy, manages the national strategic plans for STIs, viral hepatitis, and vaccines, and strongly supports the White House Office of National AIDS Policy in the implementation of the National HIV/AIDS Strategy. The current iterations of all four of these strategic plans expire at the end of 2025. So as you know, we began work earlier this year to facilitate work across federal agencies to simultaneously develop the next set of strategic plans, which will run from 2026 to 2030. In that work, we are employing a syndemic approach since the strategies address intertwined epidemics, disproportionately affecting similar populations and often sharing root causes. By developing these plans together, we also aim to identify common language as well as common objectives and strategies used across all the plans. And as we did with the current versions, we have been gathering input from community partners to inform these strategic plans since the summer. In addition to holding numerous listening sessions, OIDP, in collaboration with the White House Office of National AIDS Policy, published a request for information in the Federal Register to solicit public comment to develop the next iteration of the NHAS and the strategic plans for STIs, viral hepatitis, and vaccines. We are grateful for the valuable input and recommendations that we have received so far. At the same time, our team has been working to develop progress reports on the current national strategies, and we have recently published progress reports on the viral hepatitis and STI national strategic plans. As you are aware, last week, in collaboration with ONAP, we published the 2024 National HIV/AIDS Strategy Progress Report. This report provides an overview of 2024 progress toward achieving the strategy's goals, including highlights of federal action and the latest data on the strategy's indicators of progress. Today is the last meeting for two of PACHA's phenomenal members who have provided outstanding insight and advice to the administration over the last 4 years, Alicia Diggs and Laura Platero. Please ask Alicia Diggs to stand up in front of the room next to Carolyn. I know Laura Platero will be joining virtually. Ms. Diggs also served as the co-chair to PACHA's newest subcommittee, the Aging with HIV Long-Term and Lifetime Survivors Subcommittee. Ms. Platero, though you are continuing serving on PACHA until February, I would be remiss if I did not recognize you during your final public meeting. With deep gratitude and appreciation, I bid farewell to these two members, Ms. Diggs and Ms. Platero. On behalf of the United States Department of Health and Human Services, please accept these certificates and letters of appreciation for your service. Thank you for your unwavering commitment to the HIV response and your valuable contributions of wisdom advice to HHS, PACHA, and the nation. And as we know so well, the work never stops. It is no small feat to take on the role of being a PACHA member and a leader in ending the HIV epidemic. We are going to invite several members to continue their ongoing service as the council. It is my pleasure again to administer the oath of office to the following members for renewal to the Presidential Advisory Council on HIV/AIDS. So please join Carolyn at the front of the room. Carolyn, please let me know when everyone is assembled and we'll proceed. These are Marlene McNeese, Tori Cooper, Jen Cates, Leo Moore, and Kayla Quimbley. Are we good?
Thank you, Admiral. We have Tori, Jen, Marlene, and Leo up front, and we have Kayla virtually.
Great, thank you. Please raise your right hand and repeat after me. I do solemnly swear.
I do solemnly.
Please proceed. I'm not sure I can hear you, so it makes it a little bit difficult.
Okay, I said I was repeating. You said I do solemnly swear
that I will support and defend the Constitution of the United States.
That I will support and defend the Constitution of the United States.
Against all enemies, foreign and domestic.
Against all enemies, foreign and domestic.
That I will bear true faith and allegiance to the same.
That I will be of true faith to the allegiance of the same.
That I take this obligation freely.
And that I will take this obligation through.
Without any mental reservation or a purpose of evasion.
Without any
mental reservation.
Mental reservations.
Or purpose of evasion.
Or purpose of evasions.
And that I will well and faithfully discharge the duties.
And that I will well and faithfully discharge the duties.
Of the office on which I am about to enter.
Of the office in which I am about to enter.
So help me God.
So help me God.
Thank you. Congratulations to our renewed members. Your wisdom and counsel are vital to PACHA. Well, thank you so much for this opportunity to welcome you to PACHA's 83rd full council meeting. I look forward to hearing about the results of your 2 days of discussions about exploring civil rights, HIV in the South, and the powerful community leading progress in HIV and related endemics in Alabama. But as you know, this is my last PACHA meeting serving as the Assistant Secretary for Health. And serving in this leadership capacity has been a pleasure and a privilege and the honor of a lifetime. So thank you. But the work continues. Your commitment and dedication are more important now than ever. So thank you for all you do to end the HIV epidemic, deliver services needed by people with HIV, and lead the nation to a healthy future. As I often observe, I was there at the beginning of the HIV epidemic, and I am committed to being there at the end of the HIV epidemic. Thank you all for the vital roles that each of you play and your organizations play in making that happen. I would like to close by sharing a quote from the Reverend Martin Luther King. We shall overcome. We shall overcome because the arc of the moral universe is long, but it bends towards justice. Thank you very much.
And I hope, Admiral Levine, before you log off, if you all would join me in really giving a round of applause and, quite frankly, a standing ovation to Dr. Admiral Levine.
Yay! We love you, Admiral Levine.
Thank you all so much. It means a tremendous amount. Thank you.
Your leader has ushered in so many important changes and updates, and we can't thank you enough. We appreciate all that you have done in your service. So thank you so much.
Thank you. Take care.
Woo. Okay, we cannot get teary-eyed yet. We cannot. It's too early. It's too early in the meeting. I do want to now turn to an update and a message from the White House. Our White House Office of National HIV/AIDS Policy Director, Francisco Ruiz. I don't know, but I would say in my summation, probably one of the busiest ONAP directors that I have seen, has been absolutely on the ground running since taking on the office. And so he's got a couple of updates to share with us today, and fresh off the heels of, I don't know, his 9th convening. I've lost count. So he is busy making the work happen and engaging community. So looking forward to hearing from you, Francisco.
Good afternoon. Thanks for having me, and thanks for another great meeting. I'm excited for the discussions that are going to happen later. I wanted to share also gratitude for all the support that you have provided the office and myself. PACHA is truly sort of positioned to help inform all the work with the eyes and hearts on the ground. So I just want to thank everyone. So everything that we've seen over the course come out of HHS and other places is all because of all of you. So I want to thank everyone for that, and those who are joining virtually. I have some slides. I'm a visual guy, so I have some pictures and I have a little video clip that I wanted to share with folks. And so World AIDS Day, it happened. We survived. It was a beautiful moment. There was a lot of activity, I know, and all around the country, in your communities. But it was really an honor to have the AIDS quilt on the South Lawn for the first time, and to have our first sitting president speak over the quote was very magical. I think it was something that the building needed, what the community needed, to really have a space to sort of be with each other amongst some of the anxiety, some of the challenges, but hopefully opportunities that we have ahead of us. So it was a really great opportunity to sort of be there in community with all of you. So thank you for those who were able to make it and those who were able to see it virtually. We also issued out our fact sheet. And I'm not going to go into details, but we try to uplift a lot of the great work that's happening around government, across government. So make sure you can check that out, because these policies that Admiral Levine, and I think you're going to hear a little bit later, are only as good as people knowing about them. And so that work is really on you now. You know, the government has done their thing to try to make sure these went through the processes that needed to go through. And now we need really community members and leaders to help make sure our members have access to this information. And so invite folks to look at the fact sheet. Again, of course, the fact sheet includes global and domestic. And then we also had the proclamation. I think that the QR code leads you directly to the fact sheet. And I think you'll have the slides afterwards. But I didn't want to share, before I go into further, and I think we're going to have a video clip for those of you who are not on the gram. It was posted last week, and I just want to make sure everyone has an opportunity to sort of hear and have a part of that experience that we shared on Sunday.
The idea of the quilt was conceived in 1985. Honor the memory of all those we lost to HIV/AIDS. It started with one name on one panel nearly 4 decades ago. And decades later, 50,000 panels and 110,000 names.
And as I look at this beautiful quilt with its bright colors, the names in big block letters, renderings of lives and loves, I see it as a mom. And I think of the mothers who stitched their pain into a patchworked panel so the world would remember their child. And Joe and I are proud to have the AIDS Memorial Quilt on the South Lawn of the White House for the first time ever.
I know the fight to end this terrible epidemic is hard. I mean this from the bottom of my heart. Look around today at all of you, survivors, families, heroes, who have never given up. And I know it's a fight that we're going to win.
Thank you. It was truly a powerful moment to be there with community, as I said, to hear Jeannie Weigender also speak and the connection that she had with then Senator Biden was really great. But that was Sunday and the week continued. We did a series of activities throughout the week, and one being on December 5th, where we invited close to 100 leaders, community advocates, people living with HIV, federal colleagues, to the White House, and we called folks talk about, we honored on Sunday those that we've lost, but on Thursday we honor those that were with us. And what do we need to do to make sure that folks who are living with HIV are not just living but surviving, are thriving and living their best lives? And we had a lot of great PACHA members. We had some panelists in the room who served, and it was really a moment of reflection of all the progress and the opportunities that we have. And so I have some images. I'll go a little bit slower. We hugged, we laughed, we cried. I even got emotional, which is not very often that it happens, but it happens. I think there was a video somewhere that someone recorded. I'm going to send it to my partner. But it was a really important moment in sort of being in space, right? We talked about, of course, healthcare access and access to medicine that are life-changing, but also what are the other things that we need to survive and to thrive and to live with dignity. And so we talked about housing and mental health and economic justice. We talked about the journey of aging with HIV. We had our federal colleagues. We had several of them who are with us today, Dr. Nambler-Banfair, as well as colleagues at HRSA and CMS. But we also had HUD in the room. We had Department of Labor in the room. So it was really important to have that space to talk about all the different things. And I think there was a lot of great connections that happened. And so I committed to sort of put together a summary of that meeting because I didn't want these conversations to be lost. And so in my last 30 days that I have, there's going to be a lot coming out still. We're going to roll the tape to the end. And that's one of the things that I want to make sure that the conversations that were had at the Quality of Life Symposium, that we continue moving them forward. And this is just a little picture of all of us. Again, I think we talk a lot about joy, and we try to really sort of embody that. And we do that in a lot of the meetings that we've had at the White House. Silly, but you know what? Sometimes you need to be silly, right? The work is always going to be there, but we have to remember we have each other. And I think that was really, really important to sort of have that space with each other, and just take a minute and look at the picture, the faces, the lives that were in that room, the diversity that represents and will continue to represent our community. That we can continue regardless of what happens moving forward. This community is what has got us this far, and it was really nice and humbling to be in that space with folks. For my last convening in this role. And so it was a really great time, and stay tuned for more to come from that. And so we also, the same day, we were busy. We released our first ever progress report from this administration that included both over 13 indicators, as well as over 50 actions that have happened over this course of the year across government. And that was a lot in partnership with our National HIV/AIDS Indicator Work Group, where we convened folks from across government to help sort of put us together in 2 months, really look at the indicators, leading the charge, of course, CDC, but we had folks across HHS and other folks help me sort of thinking through how do we tell the story of the work that we've done in terms of progress, but also the work that we need to continue to do and how do we accelerate some of that. And also, of course, OIDP and HHS really helping sort of cultivate or curate all the great information that we receive from agencies. So that report, I invite folks to visit that. I think, just again, as I mentioned, some of the highlights, the QR code. We also did like a 2-pager or a 1-pager on 2 sides that has sort of some high level recap. And so I invite folks, if you haven't. Again, this work is really important. And so we need to make sure that we tell our story. In public health, we don't oftentimes do that. And we know what happens when we do that. We don't do that, right? And so we need to know that these programs are working, but that we also need to tell them that we need more support, right? We can't be humble and say, hey, we're good. We're not. we know that we need to do more work and we need more resources and support in that regard. And so that's what this report hopefully is going to help illuminate for the next administration as well as the next generations in this work. Again, I'm not going to read this, but I just want to like visually have, we had a good number of folks of the indicators sort of in the moving towards goal, but we need a little bit caffeine. We need some little a bump in there. And so to be able to meet the goals, we need to do a little bit more or a lot more in some instances. But these are all at least going in the right direction, which is promising. Again, you have the core indicators, you have the disparity indicators, and we have, again, the 5 quality of lives. Of the 5, 3 of them were going in the right direction. And then we have one that are going in the wrong direction, which this is a moment of pause and reflection. And why is it going in the wrong direction? And so as you see, we have one disparities indicator going in the wrong direction. And we know that we need to do more for folks who inject drugs, right? And then we also have 2 other ones that are going in the wrong direction under the quality of life. We know that's really important. So that's another conversation that we had at the symposium. And then we had, again, 2 that we don't have data for, and I won't go into the weeds because I think I'm almost over my time, but it's in the report. There were some changes, as you know, CDC is looking at their PrEP indicator, and so that sort of wasn't included, as well as DASH is revisiting it and recalibrating how they're sort of reporting, and so that wasn't included. So those 2 initially were included, but did not have data for this report. And the next 30 days, actually, it's less. My last day, I think technically, is January 2nd. And so I want to thank everyone for all the work and support that you have given me from day one. I've often joked being an office of one, but as I look in this room, that was not the case. I had all of you supporting me, giving me a pat on the back, telling me to make sure I drink water or sleep, which, sometimes it happened. But I just want to give you sort of a forecast of what I have planned for the next 30 days. I didn't put it in bullets, but I'm going to verbalize it. As many of you heard on Sunday for World AIDS Day, the president made an announcement, which was a pretty big announcement. There's a lot of great stuff and one-liners that were included, as you saw in the video. But one thing is that we're working with CMS to update the HIV bulletin. And I know that's something that a lot of you have asked for. So it's kind of a big deal. And so look for that. CMS is, I've been having meetings with them this past week. And many of you have shared feedback and comments around what you would like to see in the revised, updated CMS bulletin. But that is really a tool at the local level. We know that we need to do stuff at the federal level, but we also know we need tools at the local level. This is going to be a great resource for state Medicaid programs in particular to make sure that all the resources and the science and the strategies that we have available, that they're also sort of acknowledged and available at the local level. And so making sure we talk about U equals U, that we make sure that we have injectable PrEP as covered. And so I'm really look forward to that. And the other thing that I'm also going to be working on, and I actually haven't shared this with our HHS colleagues, but I want to also sort of look at all the listening sessions that we've had. And so this, as Admiral Levine mentioned, we did a series of listening sessions that were sort of syndemic in tone. But I want to pull out some of the HIV messages and sort of put together a transition document that I make public. That focuses on all the feedback that we've received over the course of the months that I've been in my position, and all the information that we've seen online. And so look out for that. So water is a yes, sleep is a maybe no, but maybe on January 3rd, which is a Friday, I will sleep. But just look for that. And I really want to, again, thank everyone for all the great work. And I want to close with a quote that was included on Sunday, and I don't have my glasses on, so I can't read it. Let me put them on now. So this movement is fully woven into the fabric and history of America. For all the lives lost, for all those that are still alive, look at what you've already done to change the hearts and minds, to save lives across the country and around the world. That's the power of this movement. That's the power of all of you. So thank you for everything you've done. Look at that beautiful picture of us walking, claiming space on the South Lawn, all the lives that we've lost, but then bringing them to the South Lawn was an honor of my lifetime. So I thank all of you who were able to join us virtually. Check out the video, it was recorded. And with that, I'll pass it over. Thanks, sorry, I'm over a few minutes.
Francisco, we forgive you anything. You can have all the minutes on the agenda that you need, and in such a short time, the incredible work that you have led and completed is phenomenal. So we appreciate you. And I know the ONAP position was not your first foray into your advocacy. You've spent your entire career doing what you do. And so, Pacha, please help me also appreciate Francisco Ruiz. Incredible, incredible. So as we started off today, we know that we intentionally wanted to make space to come and engage with communities that oftentimes get left behind. And we wanted to make sure that all of our partners and colleagues in Alabama understood not only the value, but the leadership you bring to what will be one day an ending of the HIV epidemic in the South. That's my hope, that's my belief, and I know that we have the brilliance and expertise to do it. To start us off in this conversation, we're going to hear, as you've heard, Dr. Admiral Levine give a great overview and introduction to Dr. Scott Harris. But I wanted to ensure that we all sort of understood who is in front of us this afternoon to be able to offer us a bit of a welcome to Alabama and to help set the stage and the tone for our conversations this afternoon. Dr. Harris was appointed acting state health officer for the Alabama Department of Health in September of 2017 and formally designated as Alabama's 12th state health officer in February of 2018. A graduate of Harding University in Arkansas, Dr. Harris attended medical school at the University of Alabama at Birmingham School of Medicine and served as internal medicine internship and residency at Caraway Methodist Medical Center in Birmingham, before returning to UAB to complete a fellowship in adult infectious diseases. He earned his MPH from the UAB School of Public Health. And in 1996, he began his practice in general infectious diseases and HIV medicine in Decatur, Alabama, and began serving as tuberculosis consultant with ADPH. In 2004, he helped to establish the Decatur Morgan Community Free Clinic, serving 13 years as the medical director, as well as a board member and board chair. Dr. Harris left private medicine to join ADPH in 2015 as the area health officer for 7 North Alabama counties before assuming his current role as state health officer. Pacha, help me welcome Dr. Scott Harris.
Thank you very much. That very kind introduction. You really didn't have to read all that, but that was very nice. So yeah, my wife reminds me I once was, a real doctor. Now I just play one on television, and that's what I've come to. It's really an honor to have you all here. Please let me just welcome you. We're so pleased and so proud to have Pacha here in Montgomery, Alabama. Can I ask those of you here, how many are here for the first time? How many have never been here? Oh, wow, that's great. Welcome. It's fantastic. We're very, very proud to have you, very proud of our city, and look forward to hosting you here. I do want to say in particular, thank you, Director Ruiz, very much. Really appreciate your service, your service to the American people. But it's not just American people, it's individual people who reap the benefit of that. And thank you so much for that. And to Admiral Levine as well. I don't know if she's still on the call, but her service has meant so much to us, her commitment just to the best ideals of public health. We have appreciated so much our opportunity to collaborate, and certainly wish you the best, Dr. Levine, if you're still on. But let me again welcome you to Alabama, and particularly here to Montgomery, to our capital city. Montgomery is an historic city. not always for good things, but mostly for good things. Montgomery really is the birthplace of the civil rights movement. Montgomery has long been a beacon for resilience and progress, more or less. And that's actually why it's so fitting to have you all here today as we talk about tackling HIV, which is yet another issue that really brings to mind the issues of equity, in this case, health equity, and also social justice. There's so much work that needs to be done in this area, and Montgomery is the perfect place to have you here. You're going to hear more later today about the epidemiology of HIV here, but I'll say that we have about 15,000 Alabamians living with HIV. Alabama is a really big small town, and so like any statistics, these aren't just numbers, but these are all people we know. These are our parents, our kids, and our brothers and sisters. These are real individuals. We still have 700 or so new diagnoses annually in our state. It's every one of those really is for us a sentinel event, because we feel like every one of those is potentially preventable just with the tools we have now, with the knowledge we have now, and the ability we have now. We shouldn't be seeing numbers like that. Even with the resources we have, we always need more resources, but we feel like every one of those should be preventable events. We have a lot of challenges here. We are a really rural state. If you're here in Montgomery, you may not realize how rural a state we are. Of our 67 counties, about 55 of them are considered rural. 40 of them are really extremely rural. And in that setting, we have a lot of the issues that rural communities struggle with today. We have a lot of issues related to access to care. In many cases, we have people with lower incomes who don't necessarily know where to obtain care. We have a real healthcare workforce shortage here, like many rural areas, like much of our country, but particularly in our rural areas. And that's really a difficult situation that we've been trying hard to address. We still have stigma that exists everywhere. Really, you would think in the past 50 years, we would have made more progress on that. We've made a lot of progress on that. And yet that's still a real an issue, and one that we learn affects people in our rural communities in particular. We still have significant disparities in health outcomes in HIV by race, which we haven't solved yet. It's not unique to HIV either. It's true for most of our health indicators, unfortunately, but that's still a real challenge for us. So we're working very hard to do this work. We're working very hard with many of the people here in this room. We know that we certainly can't do it alone. We need everyone pulling together if we're going to make a difference in this. We have so many accomplishments that you're going to hear about. We're very proud of much of the work that we do, but we still have just a long way to go. And again, we need your help as well. I mentioned our civil rights history. There are many lessons to learn from the civil rights story here, but just the power of collective action and people standing together to make a difference for good. That's what we need, and that's what we invite you to be a part of with us here. We welcome your input and your help and your cooperation and your collaboration. And again, we're just very, very, very pleased to have you here. So thank you all for what you do. Thank you for your service, for your dedication to this. That means so much to us here. We really appreciate it. We're very honored to have you. Look forward to getting to know you. Thank you.
Okay, we've got 5 minutes, so that means don't leave the room. You can stand and stretch, but we really want to set up and go right into our next panel. 5 minutes. Can I say how impressed I am that we have a packed, full room? Thank you for coming out. I am so looking forward to hearing from you all over the next couple of days. And so just as a reminder, while we're here, feel free to make sure that you engage with some of the members and our federal colleagues around the table. It is not often that you may have opportunity to get with folk outside of office space and really share. And as Francisco reminded us all, share our stories, share your successes, share what some of your ongoing challenges may be. But this is our opportunity to engage directly with you. That's why we're here, Alabama. So just wanted to make sure I reminded the room of that. Now we will pivot into a deeper dive. Some of you, and I hope that you express a little bit of that about your experience on the engagement visits yesterday. And many of us had an opportunity to take part in some experiences with the museum, the Legacy Museum, and other things on this morning. So definitely wanted to create space on the agenda that really walked us through the history of the civil rights movement in the South and how does that relate to disparity, health disparity, and HIV disparities in particular, even still today. And so eager to hear from some leaders here on the ground in Alabama and how their experience and their expertise might help lead us forward in what could be our solution to EHE in the South. So who will be facilitating this next panel conversation will be you've already heard our very own Alicia Diggs, hopefully soon to be Dr. Diggs, but I'm very excited that she agreed to lead this panel, co-lead this panel for her last meeting with us as a member. And then along with Jesse Mylan, and between the two of them, I don't know if you all really caught wind, but we launched that new subcommittee, people long-term and lifetime survivors living with HIV, that committee a year ago. And there has been dramatic activity and action from the two of these leaders of that subcommittee in just such a short period of time. So we already heard about the collective power and how impactful that can be when we come together intentionally to do a thing. So I will turn the next part of our agenda over to Jesse and Alicia.
Thank you, Marlene. So on behalf of my co-chair for this session, Alicia Diggs, I'd like to do some initial framing for us of this important panel. I think all of us on PACHA and all who support PACHA were very excited about our trip to Alabama to explore the civil rights history and how it infuses our work for HIV today. For us in this room who are Black, and for all in this room who are our allies, hearing and seeing in person our history of subjugation, of pain and murder, and our struggle for freedom and civil rights has been beyond informative. It has been truly transformative, a transformative trip for all of us on PACHA. We just heard inspiring words from President Biden on World AIDS Day. And as I often sit on this presidential advisory body, I think of the words of other presidents. I hear the words of John F. Kennedy, who said, "Ask not what your country can do for you, but what you can do for your country." And when I looked at the leaders on the wall of the reflecting room in the Legacy Museum today, I saw people who have given so much to make civil rights real in our nation. And I saw people on that wall who are directly connected to our work on PACHA. Alvin Ailey and Arthur Ashe and James Baldwin. And I saw blank space on the far end of that room for new names like Cornelius Baker, a black gay man who was a leader for our rights and our health, who answered that call of service to the nation for our domestic and global community living with HIV. But today on PACHA, I also hear the words of President Obama, who said in his inaugural address, "From Seneca Falls to Selma to Stonewall." He reminded us, as Martin Luther King Jr. did, that the arc of history must always bend toward justice. And Cornelius Baker was a beneficiary of our civil rights history, but he was also a leader making new history for civil rights, for LGBTQ rights, and for the rights of people living with and vulnerable to HIV, moving us always toward justice for all. And so in this time and in these months when we question whether the arc of history is truly bending in the direction of justice, it is important that we remember and relearn the centuries of struggle we've had for Black people in this country. So we've convened this panel on the history of the civil rights movement in the South and how it impacts HIV disparities today. Our pain and successes of the past can reinvigorate and inspire our work, and that we work through our pain and anger and the disparities and struggles of the present so that we can achieve greater health, greater equity, and greater rights for all people living with and vulnerable to HIV. So we're grateful to Daphne Ward and to our awesome PACHA team who recommended our speakers for today. We're excited to have these speakers share their organization's civil rights mission and the work that they are doing, and to bring their perspectives on how the civil rights movement and their work in the present can influence and guide and support our work for ending the HIV epidemic in America. So I turn to my co-facilitator, Alicia Diggs, to introduce our panel and to explain our process for today. Alicia.
Thank you, Jesse. That was beautiful. In the brief time that we have today, our speakers will be sharing in a very rich conversation on the history of the civil rights movement in the South and how it impacts HIV disparities today. I won't share their bios, but I will share their titles and affiliations. Our speakers will be Crystal M. James, Vice President of Governmental Affairs and General Counsel at Tuskegee University; Mandisa Moore O'Neill, Executive Director of the Center for HIV Law and Policy; Georgette Norman, Historian and retired Director of the Rosa Parks Museum; and our very own Daphne Ward, PACHA member, Chair of the Stigma Disruption Work Group, and Executive Director of Southern AIDS Coalition. So we'll do this conversation in two segments. We're going to first start with the civil rights history, and then those representing the work that we do today. Each speaker will have about 8 minutes, and we do ask everyone if you will hold your questions until we open the floor for Q&A. We'll start this conversation hearing from Georgette Norman and Crystal M. James, and then we'll close out the conversation hearing from Mandisa O'Neill and Daphne Ward. So with that, let's get started. So we'll start with you, Ms. Georgette, and then Ms. Crystal. We asked if you would please share the history of the civil rights movement that your organization focuses on and what you have been focusing on today that is related to our work with HIV.
Okay, I think I'm loud enough. Okay. Oh, you did, okay. How do we construct history in the absence of memory? I repeat, how do we construct history in the absence of memory? How many of you have heard the name Jackson Giles? Hands. Yeah, I'm good. In The Souls of Black Folk, Du Bois tells us, quote, either America will destroy ignorance or ignorance will destroy America. Today, I will tell you the story of the Colored Men's Suffrage Association of Alabama, started in 1902. By the 1880s, Negroes no longer held federal or state office in Alabama. Negro men could still vote, but their ballots were only negated by violence or fraud. However, Jackson Giles continued to organize under the Republican banner, was a regular at Montgomery Republican meetings, attended county GOP gatherings in the 1880s and 90s, and his colleagues sent him to the state convention in 1884. Giles's work in the Republican Party led to a position as a mail carrier in 1890, and in 1898, head janitor of the local post office, where he earned $500 a year, comparable to a skilled worker at that time. In 1900, Giles was named secretary of the National Negro Race Conference in Montgomery, convened to address the Jim Crow state constitution that was removing the rights of Negroes to legally vote. He and other Negroes in Montgomery also organized conferences on racial and labor issues. By 1890, By 1890, Giles was often in charge of fundraising at most of them. Negro County gatherings, and he and other leaders signed a declaration of principles demanding that the 15th Amendment of these United States stand in its original integrity. The 1901 Alabama Constitution required all voters to register before December 20th, requiring them to be residents, meet poll tax requirements, with some exemptions for military veterans. All those with good character and an understanding of the duties of citizenship in a Republican form of government. However, Alabama gave registrars, all white, power to decide what understanding the duties of citizenship meant. Another provision allowed the state to impose property ownership requirements voting after 1903, which combined with poll taxes, took the vote from both Negroes and poor whites. But Negroes, despite the risk, in great numbers, appeared to register to vote and faced rejection and humiliation. Giles refused to accept the indignations and led to his legal challenge. Giles versus Harris. That was a case that went to the United States Supreme Court. The first voting rights case that went to the United States Supreme Court. In 1900, Giles was named secretary of the Negro Race Conference in Montgomery, convened to address the Jim Crow state constitution that was annihilating the rights of Negroes throughout the South. The new 1901 Alabama Constitution, all voters to register before December 20th, 1902, requiring them to be residents, meet poll tax requirements, some exemptions for military veterans, and all of those with good character and an understanding of the duties of citizenship in a Republican form of government. However, Alabama gave registrars, all white, power to decide what understanding the duties of citizenship meant. Another provision allowed the state to impose. Another provision allowed the state to impose property ownership requirements, which combined with poll taxes took the vote from both Blacks and, again, poor whites. But Negroes, despite the risk, in great numbers registered to vote, facing both rejection and humiliation. These indignities led to the legal challenge from Montgomery, the Giles v. Harris case, which was the most important case that you probably never heard of. On March 28, 1902, a small group of Negro activists met at Dorset Hall on Dexter Avenue, a 3-story building built by the first Black doctor in Montgomery, about 2 blocks from the state capitol. Oh, here I am, sorry. And organized the Colored Men's Suffrage Association of Alabama, the CMSAA. The meeting was called by Jackson Giles, mail carrier, and J.L. Gier, another janitor like Giles, and two other mail carriers, P. Hatcher and J.S. Julian. Now, why do I give you that information? These were all janitors. And we look at folk of having any kind of authority and making a difference coming from the higher ranks. They're very important. More than 30 Negroes are present, many of them from the circle of postal workers and leadership positions in local churches. The CMSAA's goal was to get the courts to invalidate the voting provisions in the new Alabama Constitution, openly designed to disenfranchise the Negro voters after Reconstruction. Jackson Williams Giles was appointed president and secretary. On May 5th, 1903, 150 Negro ministers, businessmen, and editors from all over Alabama came to that same Dorset Hall to support the CMSAA and its battle to restore their rights to vote after the passage of a new state constitution that violated the 15th Amendment suffrage protections. Many had suffered humiliation at the hands of white registrars to unanswerable questions or demands for letters from white men attesting to their good character. The organization took a test case to the federal courts in 1903. Jackson Williams Giles was born a slave on January 4th, 1859. On a 450-acre cotton plantation outside Rockford, Coosa County in Alabama. In 1872, following emancipation, 13-year-old Jackson Giles and his family moved to Montgomery, where his father, Henry, worked as a gardener and mother, Clarissa, a laundress. 2824, the past isn't dead. It's not even past. In 1903, The Colored Alabamian, a magazine published in Boston, profiled Giles, calling him a highly respected citizen of Montgomery and a race leader of the right sort. Thank you.
I don't know why y'all asked me to follow her. I'm just gonna start there. But good afternoon. My name again is Crystal James, and I have the pleasure of serving at Mother Tuskegee right down the road. And from that space, which is the home of the only National Center of Bioethics that's been seated by a sitting president, we continue to try to not only educate our students, but also educate researchers around the world about the U.S. public health study of untreated syphilis in the Negro male, which anybody in public health, if you've done any research, you have at least read about this case. And so I won't spend my time here discussing with you the details of what happened in that study, because the problematic as it relates to the ethical considerations of that study and has been described by numerous scholars, many are much smarter than I am. So I will like to focus on the historical and institutional matters that made the atrocities possible and how they recreate themselves in rural and otherwise marginalized communities, not only in the state of Alabama, across the country and around the world. Economic inequities, of course, again, do not need explanation to this group. It is the roadblock or stumbling block, if you will, to many to accessing the care that they need, especially those with with illnesses that are highly stigmatized. And for those who have not been in the rural South, we are also the Bible Belt. And it is
highly stigmatized to talk about illnesses that are in any way related to sexual behavior in the church. And so the learning and education that would otherwise come from that source is not there. We also sit in a state where abstinence is the only choice to teach in our K through 12 system. And with the handicap of being unable to deliver the health messages that are necessary in order for people to prevent this and other illnesses, we also are in a space where we would normally go to where folks normally gather, because in the Black Belt of Alabama and across this country, a study that Pew put out, I think in 2018, discussed how we're the most churched and religious people in this country. So that has been historically where if you wanted to deliver a health message to communities of colors, you go to their faith-based organization and you're able to have access and to deliver, but not on topics such as these. So how and where is it safe to have these discussions? Well, what we know is that once someone comes into the academic space of higher learning, they probably have already had different access than the people we're truly trying to reach. So we have continued to seek to partner, but also to try to better educate the K through 12 systems on best practices and ways that they can actually reach, because we really need to reach our middle school kids in order to impact this in our state. It has been shown that the sexual activity and a lot of the STIs arise there. And in my role at the university, I could tell you there's nothing more devastating than to tell a freshman who has just left their parents' house for the first time at the age of 18 that they have contracted HIV. It is a devastating moment for us as leaders and of course for that young person's life, who, if they come from certain spaces, didn't even have an idea about how they could have protected themselves. So what we continue to know that it is not just the accessibility of information, it's the acceptability. How can we have these conversations in an acceptable way that has the types of policy constraints that we sit in most of the spaces where this epidemic is continuing to be, continuing to grow and continuing to have an adverse impact on people of color. The other thing that we have to talk about in context, I have in full disclosure, I'm a public health trained attorney, so I kind of speak through a lens of public health always. And, you know, I believe that what we're facing now with the abortion issues and the reproductive justice issues is going to only exacerbate this problem. Absolutely. We have people who would have normally sought care, but because they have a fear now, and they may be pregnant, that if it is found that they are pregnant, that they will now be forced to have a child. So they're not seeking care. It is, again, we beautifully describe this problem as public health professionals. But as we have looked to the work in our National Bioethics Center, as well as some of the work that our researchers are doing on the ground in other areas, we are continuing to try to create novel ways in which we can create acceptable information that can be used by the populations that need it. I think that is our real problem that we're trying to face. And the reproductive justice issues continue to exacerbate the opportunity for us to be able to engage that. Because now, even where they used to come to engage with us because they thought they might be pregnant and they can get some resources there, they actually are afraid to be discovered to be pregnant. And so people who after having had a contact that they know might have been risky or not going to share. They're not going to even seek advice because of those concerns about where they can actually get all of the help that they need, and also being held and not allowed to go into another state to get that care. We've learned the other thing that we have been learned and is actually well documented on a publication that came out of the National Bioethics Center. So if you want it, it's about the public health study and the legacy from the syphilis study. So again, it has very smart people, much smarter than me, have already wrote some very, very good articles about it. And I think it is something that would be, if you have not read it and put it into your coffers of information, that might be helpful in discussing that part of this conversation. It is a good resource. But I think we have to be clear that when sometimes in seeking to be benevolent, and it is this having a virtue of willing to do good when we can do good, that sometimes we impact the requirement or the principle of being beneficent and to provide an actual benefit. It is more than just an idea of we want to do something great. What is the action that we can put behind that to actually deliver the good to the communities that are continuing to suffer from it? Tuskegee University, still as an 1890 institution, the only private state-related 1890 institution in this country, we are mandated to be community engaged. And so we continue even on front doorsteps, in cornfields. When you think about the syphilis study and the work that Nurse Rivers did, while you may have concerns about the ethics of it, the actual ability for her to be able to engage in the community and to be able to get them to respond to her, that is trustworthiness. That is the concept that I think we all have to build, not just trustworthy, right? Not just having trusted information, but it coming from a trustworthy source that is accepted and trusted by everyone. That's important. And I think as we tell the truth and speak truth to power, we're able to maintain that trustworthiness. And that's something that in this moment and in the moments beyond that we have to hold ourselves accountable to, is being those trustworthy voices that will actually deliver messages to these communities that they can use, and not only that makes it accessible, but acceptable where they live, work, and play. Thank you.
Wow. Thank you both for the powerful history, though brief, and the work that you all have been doing. We could spend a couple of days on this. But in the time that we have, we'll move on to part 2 and start with you, Mandisa. And though you can definitely share as you have in your heart, but just to kind of guide our conversation and your work today, and this is for you also, Dafina. You're living in this history and you do this work in HIV. Tell us about how this is impacting the disparities of HIV in the South as you do your work.
Just thank you, first of all, for inviting me and for grounding us in the way that you did. 2 things to start with. So first, I'm a Black Southerner. I come from Black Southerners. I'm married to a Black Southerner, and it is how I lead this national organization. And I refuse to learn any other way to lead a national organization and then be rooted in the practices of my people. So that. The second thing is, if you've heard me speak before, I often start with a quote because I like to read and like to share what I read. And all those sort of nerdy things. And folks often hear this quote, as goes the South, so goes the nation. I think that's one that folks have heard. And we often don't know where it comes from. It comes from William Edward Bernhard Du Bois in one of my favorite books, The Souls of Black Folks. And that is super important as a text. And it's super important in this topic, one, because he introduced like this idea of the double consciousness, right? This idea like Black folks are constantly having to navigate our world and this other world that like literally hates us. Like that is the dance that we do. So one question I have is thinking of all of the ways like that we do HIV work, how does that then play out in our services? How does that play out in our testing and our policies and our prevention efforts? This idea that many of the folks that we engage have to navigate systems in a way that is speaking to like this dual consciousness is one thing. The second thing like that I really wanted to think of with him is I believe he was actually writing in a similar political moment that we're in. I understand PACHA is a particular body. I'm not on PACHA, so I'm a political person. Like my organization is law and policy. I would not be doing my job if I did not offer like a certain lens. So I just want to say that. But that moment, like the white backlash after Reconstruction, is the moment that we're in now of the white backlash after the perceived gains of having not one, but two terms of a Black president. So for me, it was important to start with him because, you know, oftentimes like we think of progress as like forward. And I actually think, and my spouse, Wendy, often says that there's so much that we can learn from looking backwards, because Black folks who lived then were actually closer to freedom before enslavement than we were. They actually have memories of things that we don't actually have. And I think it's helpful like to think of writers who are writing in the moment that we're in now, like extreme backlash, like to perceived gains. And also, if we think of the world that existed in the South after the US pulled out of the South, that's a form of economic and political divestment. I don't know what else to call the moment that we're in, if not a form of divestment. So again, he has so much to offer us. And that is the context we're doing current HIV work in this context where there has been a divestment of housing, of land, of what does it mean that the people who work the land historically and currently don't have the means to own it, don't have control over that land in terms of housing, like in terms of environmental factors. What does that mean in terms, again, of our work? Again, when we think of HIV, it's inevitable that the South is a region that has these very stark sort of disparities. I remember like when I first came into HIV work in like 2006, 2007, which was a very particular context of post-hurricanes Rita and Katrina. I'm from New Orleans, so that's where I got into this work. And like it was all this data of how HIV in the US South was very similar like to HIV in the global South. And that always sticks out to me in terms, again, of the context that we are doing this work. Like oftentimes when folks think of the South, folks lump it into one kind of place, when actually there's a deep South, there's the Appalachian South, there's the Gulf Coast, like there was like the coastal, like the East, you know, it's all these different parts. And then like wonder why our strategies for the South don't work. We can't tell South Louisiana from North Louisiana. And then it's shocking to them, but to us, it's like, well, I could have told you that. You tried to have a meeting in New Orleans and you didn't provide hot food for people. You tried to extract from already extracted people and didn't put anything in and wonder why no one's talking to you. But when I come in, because I know how to act, I have not only formal training, but I have the home training of how to work with my people. So I know how to come in and get the same information you were struggling to get with all these grants. And so that a legacy isn't just one of chattel enslavement, right? Like it's also one of enslavement's children, which is the prison system. So our work at CHLP is mostly like around how we as a country have responded to this epidemic with punitive responses that incarcerate people as opposed to actual health care. And, you know, like this is such a place that shows that, like all the stats show it. So in my home state of Louisiana, Black folks make up less than half of the state population. Over 92% of who's first is arrested, who is charged, and who is sentenced for HIV criminal statutes. That is wild. Tennessee, Marvell, you know, like Black women make up less than a fourth, yet over 2/3 of who's incarcerated, again, who's arrested, who's later charged, and who's sentenced, because again, those are different intervention points. You can be arrested for one thing, charged for another, sentenced for another. So if we're serious about addressing criminalization, we have to look at all of these entry points, like not just one, but make up over 2/3 of who at all those entry points, Black women, cis and transgender. So Florida has similar numbers, Alabama, like every state. And so last thing I will say is that's, you know, important in this conversation, because thank you, Ms. Norman, for like talking about like the importance of the many struggles and the organizing to vote. You know, in almost every state, these criminal laws are felonies. What's the one thing about a felony? You can't vote. In some states, at any time, if you had a felony, in most states, you can't vote, like as long as you're still on papers. You know, in addition to racism as a huge barrier of voter disenfranchisement, how are we thinking of HIV criminalization as an additional barrier to our people, like from being able to access systems, like as far as like I were told to empower. I also think of what Dr. James said as far as abstinence-only education. So CHLP, like at our core, like we're a research organization, right? I always tell the staff, it's not possible to craft policy if we're not researching, if we don't have like a grounded assessment of what it is that we want. How do you do that? By like looking at data, looking at research, but also understanding like that the data comes from the people. How do we also value the people? And in that, it's just important to name that most of what we know as abstinence-only education comes out of the Welfare Reform Act. What's the connection between like these ideas of who was on welfare and whose body needed to be controlled and these ideas of abstinence-only education? If we knew that, would it then change our policy approaches? Like, would it change like how we're engaged in this work? Like, would it change, as you talk about like how we engage folks who are worried about possibly being pregnant and also thinking of testing? I also think of, that was 96. And 94 was the 94 crime bill, which had, I would argue, a most pivotal impact on the rights of not only that generation, but of generations to come, in ways that I don't even know if we fully understand the grasp of what that crime bill did, not to end crime, because obviously it didn't, like, let's name that clearly. But to exacerbate these disparities that many of us understand are the root of HIV. This is the real last thing. I was out of order in my notes. I do apologize. And again, like thinking of this region, oftentimes like folks think of like the importance of policy wins. And I always think of the organizing and activism like that made the policy wins possible. And oftentimes like people start that conversation with ACT UP. And I understand why. And as a Black Southerner, those aren't my reference points. If we're talking about HIV activism, cultural work, and we're not talking about Catherine Haywood and Danita Muse, two Black women in the 80s who started Women with the Vision in New Orleans in the Calio projects in terms of they saw what was happening in their community, but didn't see the resources because no one was white in that area and everyone looked how they look and didn't fit the idea of who we thought HIV was. Hemp Hill, is a part of that conversation. Marlon Rigg, like those are the folks who anchor me in this work. And I don't think it's just me. So again, like how do we make sure even the work that we're doing now, it's rooted in the people and in the stories that actually make sense. So.
I thought if I went last, I could just say amen when they finished. Ooh. So, I am sitting in a lot of feelings, and I want to acknowledge that because I believe a lot of my PACHA colleagues are also sitting with a lot. We had powerful engagement visits yesterday that took us to organizations in Montgomery and then also took us to Selma, where we got to sit at the foot of Joanne Bland and hear her story as an 11-year-old girl being a part of that march, that historic march, that walk from Selma to Montgomery. And so in reflecting on this connection between the history of civil rights, human rights, historically here in the South and the work that we do at Southern AIDS Coalition and just the general movement for HIV justice in the South, I'm taken to the document that really led to the creation of our organization. So back in the early 2000s, before Southern AIDS Coalition was really an organization, there were state AIDS directors and community leaders like Kathy Hires, former PACHA member, who got together and created a demand, a manifesto. And the Southern States Manifesto is a powerful document with a call for justice and a call for change and transformation and ending HIV disparities in the South. But we have to take a step back to the original Southern Manifesto, which was a 1956 declaration by congressional leaders, senators and representatives from formerly Confederate states who got together to tell us why Brown v. Board was unnecessary. And they declared in what they called, this whole idea of a manifesto of constitutional principle that racial animosity does not exist in the South. Why do you keep trying to create these problems? And so I think it is very important as we talk about the intersections, these opportunities for us to do true justice and transformation work in ending HIV disparities, that one, the messenger matters, whose voices are heard is critically important. And also recognizing that HIV disparities is on a very long list of relics of slavery. As we talk about mass incarceration and we talk about sharecropping and Jim Crow and Black codes and all the things, that what we see happening in our communities definitely is a part of that list. So I wanted to bring to the conversation as we're having this discussion and talking about civil rights, and also this year's World AIDS Day theme around collective action. What does collective action mean across movements? And so there are 5 areas I want to name that we saw very much historically as we examined the civil rights movement in Alabama and across the South. And as we talk about what's needed in this movement towards ending the HIV epidemic in this nation and in this region in particular right now. So the first would be alliance building. Alliance and coalition building was critically necessary in the movement for justice and civil rights. We saw that. We saw that if we visited the Legacy Museum, we've read about it in books, all these unlikely alliances that had to be created and formed because we had one common cause: justice, freedom, equality. It doesn't mean everybody got along every moment along the way. It doesn't mean everybody agreed on everything, but there was a singular cause. Just as we have a singular cause in this moment to end HIV disparities and create health justice in this region and across the nation. The second is intergenerational mentorship. We heard so much about the power of young people on the bridge, training in churches, marching in streets, often because young people didn't know any better. And often strategically because they were perceived as having less to lose. And in this moment, as we talk about how we end HIV disparities, the necessity of an intergenerational approach, a commitment to an intergenerational workforce and movement. Thirdly, the understanding of systems. What we've heard today, we've talked about voting, we've talked about labor, we've talked about education, we've talked about economics, we've talked about our criminal justice system and understanding of systems across the board. People like to quote Dr. King a lot. Dr. King understood the power of an equitable labor force. It was not just about Black and white together in content of character and not color of skin and all that stuff people try to say anyway. But a true understanding of systems and working across systems. Then litigation and policy. Understanding, and Mandisa spoke to this, the necessity of research, but understanding the role that policy, that law change, that all of that plays, and the necessity of changing laws in addition to changing hearts and minds in order to create change. And lastly, the power of media. We talk so much in this work about stigma. And what we've seen as we've examined this history of civil rights is just this constant power of othering. The importance and the necessity of making someone less than. And that is what we see so often in our work. We allow our family, our friends, our loved ones living with HIV to be othered. We allow folks who've been historically marginalized, who come from a range of lived experiences, to be othered. And that othering then creates this sense that they lack credibility, that they lack the credentials, that they lack the expertise. And we know that's simply not true. So I just challenge us as we leave this place and we've had this experience and this conversation, I know there will be more dialogue, for us to think about our work in ending the HIV epidemic through the lens of what we have learned as we've talked about the power of history and what's past and how we apply that to that work moving forward. And recognize, and I believe Joanne Bland told us yesterday, that this movement is a jigsaw puzzle. And if your piece ain't there, the puzzle's not complete. And each of us have a piece and a role to play. And lastly, I'll say, Southern AIDS Coalition will be releasing an update to the Southern States Manifesto on this Friday. You can watch it on our socials at 3 p.m. Central from historic 16th Street Baptist Church in Birmingham. This work must continue, it must go on, and we must do this work together. Thank you.
Wow. I would just love for everyone to just think, Dafina, Georgette, Crystal, and Mandisa for sharing what they have, these pearls of wisdom today. We're looking forward to a part 2. We do want to start with our Q&A. We have about maybe 20, 25 minutes or so. And we definitely want to open the floor to our members and our federal partners with any questions for discussion. Now let Jesse take it over.
So one diva, one mic. One question per person, and we'll try to keep this brief, but also your reflections on what you've heard today is also important because those reflections can help infuse our work. So the floor is open. Put your table tents up and we'll keep an order, and we will end this session by 4:30. All right, Branya, why don't you start, and then we'll go to Guillermo.
I was hoping you were going to go to somebody else first. It has been such a beautiful, emotional, and really moving time thus far. This is not my first time to Alabama, but it's the first time to be here and feel like this, and to hear from the organizations that we heard from yesterday. And this panel was quite exceptional, I think, particularly for me, capping off the experience of going through the Legacy Museum and thinking about the impact that slavery and all of its remnants have on our work. You all know I co-chair the Stigma and Disparities Subcommittee with Dr. Leo Moore. And one of the things for me that made me passionate about really kind of stigma and disparities work is because I really do see stigma as a vestige of racism. And I feel like in our HIV work, we don't have great examples of how we connect anti-Blackness and racism to stigma, right? Because it's very much about othering. It takes so many people to help. Wonderful. This type of girl I am. Thank you. Yeah, I'll take that. But I do think that stigma is one of those things that it's very much about othering. And I think, this is my belief, that we use sometimes the word stigma because the term racism feels very like, oh no, we can't say that, right? Well, nobody here is racist, right? But we can say that things are stigmatizing. I think that's a challenge that we have because it's not named, right? We don't talk about how the language that we use others people, how the language that we use others ourselves sometimes. And so my question to you all is, what programs have you seen? What efforts have you seen organizations that do it really well, that really help connect the dot between racism, anti-Blackness, and the way we do HIV work? Are there trainings that you've heard of? Because I personally have been in this field for a while and I haven't seen it done well. And I think that as we go into this next kind of period of our HIV work, being able to name the things, being able to say, this is how we do it differently is going to be critically important.
I would agree with you that we don't do it well. And I think that is where that alliance building is going to be so critical for our movement. The necessity of getting outside of our HIV specific silo to deal with the fact that we are dealing with even broader societal challenges is necessary. There have been we've seen people dip their toe in it, and then it seems like it comes right back out. And so I appreciate you naming it because we know that it needs to be a part of every conversation and every program. I want to challenge us specifically around how it shows up in our workforce, because I think that then reverberates in how we are treating the folks we serve. So often we have these conversations in organizations where folks talk about feeling like the HIV workforce is snow-capped, meaning that all the folks doing the work are Black and brown, but at the top is going to be white leadership that doesn't provide that space for access and growth and opportunity. And I'm naming that as a challenge for us, I think, as a movement, for us to create more spaces to have those honest conversations so that we can build impactful programs The most impactful work I've seen around addressing it has been peer-led work, where folks are having real conversations about their experiences in community. And we need to support more of that and find out how we, those of us who are leading and building work, can then learn from what is truly happening on the ground and where that work is happening. And I don't know if I answered your question, Rania, but all right.
Something else, like, and thank you for that. Like, first, yes, I totally agree that it's not many examples that I'm aware of. And I think that's intentional, because I think if we were to have the actual sort of conversation about race and racism, it would literally turn everything upside down. So I want to just like name that. And like part of what I see is oftentimes like we're in spaces with people and we don't even have a shared understanding of what race is, of what power is, like of what power is, but also how it's arranged in like any given space. And also like what is systemic, like what is institutional, what is interpersonal, the differences. So I think that is often a place where I'm like, so we're using this word. And when I say race, I can give you a definition. It is a social construct that's real in its like application, but you think it's something else. And I think that People's Institute, an organization that actually started in New Orleans, but does trainings everywhere, I think has a really helpful framework around race, racism, and also like what it means to be anti-racism. Now that's not HIV specific, but they do trainings often like with folks. And then it's other orgs like who have like more of a racial justice framework as well that is always so necessary. And my experience also is like if it's talked about, it's like a one and done, right? Like, oh, check, I've done this thing and now I can do the real work. So a question like that I always have is, what does it mean if we're never done doing anti-racist work? Like, what does it mean if we're always in this process of unlearning what literally took 400 years of learning? So.
I'm really quick. And I think what we all need to do is to learn to listen. And to learn to listen deeply enough that you're changed by what you hear.
Guillermo, and then we'll move to Philip.
First of all, thank you to the panel. I will echo what Rania said. I think for all of us, it has been a very special visit, especially at the moment that we are. And I appreciate your amazing voices, because validation to me is critical, you know, in a moment when we need to seek. And I've been saying to folks that we have to follow the South. The question for the nation is if we are prepared or we're humble enough to follow this South. You know, that's a question that I think is a very powerful personal and collective answer. But I also want to add that many times we say we're a nation of, and I have been saying lately, we're a nation of Native nations. That is an open wound. We're a nation that have slavery part of our history, open wound. And we're a nation of immigrants, you know, and also an open wound. And then the collective healing from a public health perspective, I think is going to be very powerful. And I'd like if you could share a little bit, a couple of strategies, how we can do better building partnerships and alliance, dealing with those open wounds, and at the same time, building that common path, common ground in this context of ending the HIV epidemic. Thank you.
I'll just say briefly, for those who visited the Legacy Museum, there was a video showing the unimaginable number of Africans kidnapped, captured, and trafficked. And it was so powerful to see where they were taken in North America and South America. I don't think we have enough conversations about history to build alliances that could be transformative. When we talk specifically around the relationship between Black and Hispanic and Latinx community and work and organizations, we don't talk enough about our shared history and our shared pain. We talk so much about our differences. So I would challenge us to do more of that in order to create really transformative partnerships and not be scared to go there in those pains, those open wounds that we share, because many of us share many of the same wounds, and we don't talk about that enough.
I would like to add, there's a great book called Intelligence that talks about the difference between the generations. I think one of the things, in order for us to actually be able to get some better traction in this, is we're going to have to be able to talk to millennials, Gen Zers, and there's Gen Alpha now. I can't remember what the next one's called. But although our generations collectively carry these wounds and we understand the history, we truly understand that where books were a good resource before, it may not be a good resource for that generation. And so her comment about listening and actually capturing the lived experience of some of the elders, but also figuring out a way to make it accessible to those later generations, because they're going to be the foot soldiers that actually help us do this work. But their America is different.
So I also think like asking the uncomfortable questions, like a question that I, prior to like being an attorney, I was a youth organizer, and like this was like a common thing about they have this, and so like very quickly, who is the they? And a question I would always ask is who benefits from that group of people being your enemy? And like it's actually not a theoretical question. There is a distinct group of people who benefit from certain groups who are at the bottom fighting over a crime. Like that's, it's literally not theoretical. And like also adults, like we should also ask ourselves, you know, like as leaders of institutions that are often pit against funding, like let's just say what it is. Like it like also serves us to ask that question and to be super intentional, like as far as like how we answer it. And then of course it's some other questions like that comes from that question of, well, how do we know? How do we acknowledge that and then work around that? Like, how do we undo that? But that to me is a starting point, like as far as to unravel how we're told. And again, I'm not on PACHA. November 5th illustrated that. Like if nothing else illustrated it, and clearly it was many other examples, but the 5th of November showed you just how successful their organizing is. And, you know, some gaps, you know, in places like where we could, oh, okay, we were uncomfortable to have this conversation, but somebody was having it, and we see the result of that.
Dr. Champ.
Yeah, I just want to thank the panel. Thank you for hosting us here in Montgomery. It's my first time. I've been to Birmingham before, but not to Montgomery, and it's been a pleasure for all of us, I think. So I'm a physician. I'm a primary care physician. I spend most of my days talking about sexual health. I want to ask you all a question, and specifically something that Crystal mentioned, and Dafina, you kind of touched on as well. I totally agree that we have to compromise and build alliances. I struggle, though, when the conversation revolves only around abstinence. And I'm just curious about your experiences in Alabama, because it's difficult for me to imagine having a productive conversation when you can only talk about abstinence. And certainly I'm willing to compromise. I understand that sometimes we have to meet in the middle. But how have you achieved that in Alabama? And any thoughts moving forward as well?
Well, thank you for the question. The quick answer is I don't just talk about abstinence. I just don't do it in spaces where it's illegal not to. And that's the hardest piece is that again, the church has been always a good pivot point, but in the Bible Belt, that's also a tough sell to say, hey, I want to come in and do sex education with your congregation. Yeah, they're not letting me in that door either. So we have had to create opportunities to engage with students through other avenues off of the K through 12 ground. So we got to be able to bus those students some other place where it's acceptable to talk about it, because you have to. There's no way that you can get this work done and not speak about sex and how diseases are actually transmitted.
From my previous experience working in prevention in Alabama, I would say that the CBOs in this state do such a tremendous job of providing that education that the students will not be able to get in their school settings. And in my experiences in working, particularly in rural communities, we did partner with church youth groups and community centers. But was the most impactful, though, where we would typically, the night before we were going to spend a day doing intervention with adolescents, we'd have an evening with the parents and their guardians and educate them. And it was amazing what they just didn't know. They were blown away. I mean, the whole point was, let's show you what we're going to teach your kids so you'll know. And we'd have so many folks, I didn't know that was a thing. You know, and so I think that there's this opportunity for just this intergenerational learning that we have to do a better job of taking advantage of. And we've definitely seen that work.
Chair Marlene.
And Dafina's last comment sort of took a bit of my thunder away. I definitely, also have to thank the panel. And where I sit, obviously in Texas, there are lots of similarities, and we heard about that at a meeting earlier in the year. But I wanted to lift up one of the experiences I had recently. And that was, when we worked out our Ending the HIV Epidemic plan in Houston, one of the things that we found that in our past sort of several decades of planning around the HIV work, that all we had done was created plans that said how we would use the government money. We had not created plans to end the HIV epidemic. So when we changed our intention, it really began to mobilize how do we wrap our minds around the mobilization necessary for things not necessarily government supported, not giving government off the hook. That's the whole reason PACHA exists. We are here to challenge and charge the government with a response to HIV. However, as has been said since the first iteration of NHAS, the National HIV/AIDS Strategy, that the government alone is not going to do it. So I lean toward what is necessary for mobilization and how might we do that differently moving forward, especially in challenging spaces. And it centers for me, at least in Texas, just wanting to hear some of your thoughts around simple messaging, clear and consistent messaging and approaches. Because I think oftentimes we get really wrapped up in what complex strategy needs to occur, and we lose the people that we're trying to reach. And so I'm glad that you mentioned that, Mandisa, about what worked and what we saw worked on November 5th. I certainly saw it in Texas. It took one simple message, and that message was resonated over and over and over again, and it worked. So I'm hoping that the application to that for our path ahead for EHE, I'm actually now on the other side of my feelings. And so I'm quite hopeful and intentional and feel a sense of urgency about making sure that we do have some approaches that reach folk in a different way. So thank you for your conversation and what you brought, intergenerational learning and mentorship, Dafina. I wrote it down and will highlight it. It will be my charge for the next year. So thank you all for that.
I just want to say that, based on what you were just saying, okay, I'm sorry. In the early days of AIDS, everybody was kind of flustered, not knowing what to do, anything. My partner and I decided we were going to go where we had a captive audience. And that was in barbershops and beauty shops. And we'd go and, nobody was going to leave with their head looking crazy. So they'd be there. And we just talk about, what they thought about it, how it was, and try to remove some of the stigmas. And the idea is that we are human beings. And what we have to do is begin to act as humans. We need to be humans. And I think when you begin to think about that very differently, you begin to say, that could be me. Or it could be my aunt or my sister or my brother, that I don't know is going through this. And we used to have some fantastic conversations because they're captive, and they listen and they begin, and as you talk, they begin to talk about it. And they don't have to get personal because we aren't getting personal about it, but at least it opens up a window for conversation.
We'll go to Paul and then we'll wrap up with Carol.
I want to say thank you for the privilege of letting us be in the space while you talked. It was a series of conversations that we've had over the last couple of days. And Delphine, I really want to thank you for introducing me to Joanne Bland. She was a salve that I did not know I needed. It's been tough. It's been real, real tough. And I want to thank my PACHA colleagues who kind of saw me fall apart. I needed that desperately because we have a big fight in front of us. And I am trying to figure my way through what's ahead of us. And I worry. I worry for all of our communities in ways that I can't say at a PACHA meeting. But this is the one thing that I can say at a PACHA meeting that I think is very, very important. We need to remind the new administration that President Trump was the president who started the ending the HIV epidemic. And we hope that he will continue his commitment because we are within reach and we can make a difference, but we need his support.
Carol Trustin.
Thank you to the panel and thank you, Dafina, for really organizing this transformative. Somebody said it was a transformative 2 days. It truly, truly is. I want to hit on your those five collective action steps, and in particular, alliance building. This PACHA meeting and many of the other national and global HIV tables that I've sat at are very diverse, and they're all very representative of different sectors and factors. But yet, there always is a feeling of, well, if somebody else, some other organization, some other entity gets something, then I may lose, right? And I want to bring to this table, I'm actually stealing Vincent Ramos's remarks over and over again, that we really need to internalize and incorporate the and not the or. And he mentions that over and over again, that if there's one group that's focused on, and then does that mean somebody else is left behind? No, no, it has to be the end. And one of the things that really struck me in this change that has happened in the last, 30 days or less, is how successful some in the opposition were at pitting one group against the other, right? I mean, again, somebody talked about, it's the poor people at the bottom who are fighting against the others, and then who really wins, right? I mean, this is the great example of that, and how that campaign was so, how that moment was so successful in pitting Black men against transgender individuals, about pitting immigration, folks who are coming from other countries against poor white people. You know, that was a stunning example of pitting people against each other and who wins, right? And so how do we really get over that as a movement? Because I think that's something that we do have to acknowledge, that even in these very cooperative settings, there still is sometimes that feeling of, somebody's going to gain and that means somebody has to lose. So how do we build alliances that are really meaningful to move the fight against HIV forward?
Well, first, I think it's helpful, for us to acknowledge how that organizing has impacted us, right? We also have a lot of those same, I would say all of those same issues, within our movement, like it was mentioned in terms of snow capping, but also these ideas of, how Black men get characterized, especially Black gay and queer men. So that's where I would always think it's helpful to start is yes, it's happening and we've seen it. How am I too being organized in ways that maybe I don't even understand? What are the things it's helpful on me to have some further questions about in myself, in my org, a lot of people here who lead, organizations. I'm also thinking of Paul's statement. I respect that as a strategy, and for CHLP, for CHLP, our work is going to be making as many interventions to stop the harms of not just this administration, but current harms happening, as far as folks being arrested, testing policies, all of those things. And I think that's the nature of alliance building, is how do we have trust that we're playing our role? That yes, it's someone who is going to be in that conversation about, hey, it happened before, it needs to continue. How do you also trust that we'll be a part of a group of people doing our best to hold the line and to stop the harms that are happening to our people? And I think that that is a strength of being in an alliance space, is we don't have to all be doing the same work. Now, it can't contradict or counteract each other, obviously, because that just is nonsensical, but it doesn't have to, as far as all of us doing the same work. But that's what comes to mind. How do we check ourselves and check our assumptions and check our areas of bias? And how do we also be clear as to what is our role?
Crystal, one last point.
Yes, I would like to add a concrete example of how building an alliance actually has worked and actually helped engage at the federal level. I'm principal investigator for a HRSA grant around maternal and child health. And that we came together as a coalition of people who are interested in resolving this issue in public health programs and minority serving institutions. And we met together for over a year together, looking at sharing best practices, helping each other to build. And we approached HRSA to say, hey, we have collectively been working together. You need to write a NOFO that will help us work together better. And this is what it should say. And they actually did that. And 17 of us were funded last year to do this work for a 5-year cooperative agreement.
Love it.
So that's a concrete example of one way that you can build alliance, but you got to be in community first and have a shared agenda about how we want to make this approach. Now, we all have different, I'm in rural South, so of course my research center has a different focus, but we all have the clear objective to decrease maternal deaths and decrease infant mortality. And we all came together to say, hey, these are the strategies that we think are important, and this is how you should fund it. And these are the people we think you should fund because we're already working together.
Thank you. Well, we've come to the end of our time, but as Alicia said, this is our last joint venture, Alicia. As Alicia said, we could have this conversation for years. But if nothing else, this amazing panel from Center for HIV Law and Policy, Tuskegee University, Southern AIDS Coalition, and the Rosa Parks Museum have reminded us, and these 2 days have reminded us, that the HIV movement is also at its heart and soul a civil rights movement.
That's it. That's it.
Thank you to our panelists. Thank you to Alicia. And back to you, Madam Marlene.
Yes, indeed. Let's give Jesse and Alicia a round of applause. Thank you. Thank you. Our conversation continues. We are going to govern ourselves accordingly. We have a 10-minute break, and we will come back where Dr. Sullivan and Tukes will walk us through some epidemiology for here in Alabama. Thank you. 10 minutes.
Produced by the U.S. Department of Health and Human Services.